Hello and welcome. I'm Erica Seamers, the Regional Executive Director for UCHealth Northern Colorado Foundation. It is a pleasure to have so many donors, community members, and supporters gathered here with us over the lunch hour for a very special presentation on cancer care in our community. A little background on the UCHealth Northern Colorado Foundation. We support Poudre Valley Hospital, Medical Center of the Rockies, and Greeley Hospital through donations made by generous community members. Donor contributions help to fill in gaps not covered by insurance and to accelerate advances in medicine, ensuring the very best healthcare for our region. Community support like yours helps us to care comprehensively for the health of our community. As just a few examples, our foundation disperses an average of about $3 million a year to support a broad spectrum of programs across our hospitals and clinics. Donor generosity has helped to bolster our frontline healthcare workers and to equip our hospitals since the onset of the pandemic. Additionally, generous donor contributions helped us to open our cancer center here right in Fort Collins in 2014. In fact, we're broadcasting from the Cancer Center today in the Carroll Family Conference Room. Since then, gifts from individuals, businesses, and foundations have helped us to continue to advance care and bring care closer to home. Most recently, some philanthropic dollars were used to purchase equipment to establish a new gynecologic oncology program located here in our region at the Cancer Care and Hematology Clinic at Medical Center of the Rockies. We'll provide a Q&A, opportunity for Q&A at the end of today's presentation. If you'd like to ask a question or share a comment, you can click on the question mark icon in the top right corner of your screen, and then type into the Ask a Question box and click the arrow to submit. With that, it's now my pleasure to give a brief introduction for each of our three speakers today, Dr. Diana Medgyesy, Jamie Callahan, and Jonathan Salazar. Dr. Medgyesy is Medical Director for Genetic Counseling Services. She is originally from Romania, where she completed medical school. She received postgraduate training in internal medicine at Yale University and New York Medical College at St. Vincent's Medical Center in Bridgeport, Connecticut. Dr. Medgyesy received fellowship training in medical oncology and hematology at University of Texas and MD Anderson Cancer Center in Houston, Texas. Also presenting today, you'll hear from Jamie Callahan. She's a team lead for the oncology nurse navigation team in our region. She has been an oncology nurse for 10 years and a nurse navigator for 7 years. And you'll also hear from Jonathan Salazar, who is the Regional Manager of Supportive Oncology Services. These services include nutritional counseling, psychosocial support, genetic counseling, integrative therapies, medical interpretation, and palliative care. He has been with UCHealth for 14 years, 6 of which have been in supportive oncology. Again, thank you all so much for being here today. And now Dr. Medgyesy will kick off today's presentation.
Thank you, Erica, for the beautiful introduction. I want to give thanks to the Northern Colorado UCHealth Foundation for making this program possible. This is a wonderful opportunity for me and my colleagues to talk about the passion of our life, taking care of cancer patients. This, I'm hoping, will give you a great opportunity to see what we're doing in the day-to-day trenches of cancer care. I would like to discuss today about the multidisciplinary care of the cancer patient. I will start, first of all, with the changes that have come along in cancer for the last 30 years, of which I've experienced 21 of. A little bit of background about myself. I've been practicing as a medical oncologist for 21 years, and I've focused on breast cancer and gynecologic oncology for at least 10 years of my recent career. Dr. Bernard Fisher, who I have on this slide, who graciously lived for 101 years, is considered the father of modern breast cancer treatment. He, as a surgeon, is one of the first leaders in breast cancer field who noticed that actually by the time breast cancer is diagnosed, it's the tip of the iceberg, and the disease is already spread microscopically to other parts of the body. And the treatment of the local therapy of the cancer is not what brings the most success in curing the cancer, but it's the treatment of the whole body that leads to cure of cancer. And instead of debating his philosophy, he actually was the one who put together randomized clinical trials, which are the pillars of discovery and forward movement of cancer treatment. Randomized clinical trials are the pillar and everything that we do today, taking patients with the same disease, same features of health, and allocating them to treatment A versus treatment A plus B, and then compare them over time to see which treatment is better. So he was the one who put together randomized clinical trials that brought forward what we know about treatment of cancer today. So in the last 20 to 30 years, what we've done in breast cancer is less surgery to the breast and axilla being the underarm area on the side of the breast tumor where cancer could spread, which are the lymph nodes. So trying to minimize surgery to the breast and the underarm area to decrease the risk of long-term complications without compromising the cure of the patient. So the clinical trial that was put together looking at removal of the whole breast, which is a mastectomy, versus removal of the tumor, preserving most of the breast, followed by radiation, could lead to the same chance of remaining breast cancer free and living to be 110. So more surgery is not necessarily better. So we have this now 20-year follow-up data. The other great discovery and improvement in our care was the discovery that we don't need to remove multiple two-level lymph nodes in the underarm area, which is an axillary node dissection. It's sufficient to remove the most 1, 2, or 3 superficial lymph nodes in the axilla, called the sentinel lymph node biopsy, without compromising the outcome of the patient, but decreasing the risk of complications of the axillary node dissection, primarily arm swelling, which is the dreaded lymphedema that can sometimes stay with the patient 30, 40 years, stiffness of the shoulder, decrease in the range of motion of the arm. So there were 2 large randomized clinical trials, the Z11 and the NSABP B32, that randomized patients who had cancer in the most superficial lymph node, the sentinel node, to either more surgery, which is the axillary node dissection, or no additional surgery. And what we learned is that the cure rate of cancer was the same. The risk of complications from removal of too many lymph nodes was much less. So then what we moved forward with was becoming smarter and sharper with our treatment of the rest of the body. As you recall from the first slide, we said that cure from cancer does not come from treating more of the breast and more of the axilla, but getting rid of microscopic systemic meaning the whole body presence of cancer in other parts of the body. So getting rid of those microscopic seeds of cancer is what leads to cure. So what we have done is select patients who needed more aggressive treatment versus patients who didn't need more aggressive treatment. So 21 years ago when I started, we had a patient who was 55 and she had a 1 centimeter tumor in the breast. And we rolled the dice and we said, you might be cured with surgery, but maybe you need more treatment. So it was a long discussion of, well, this is the risk with treatment, without treatment, and it was just a leap of faith on choosing what to do. Well, nowadays we have what's called molecular profiling, or better understanding of the genetic makeover of that individual tumor that will tell us exactly, is this an aggressive tumor that requires chemotherapy, or is this the slow moving giant that's slow growing for which anti-estrogen therapy is enough? So with 2 randomized clinical trials that have been going on for the last 10 years and completely accrued and followed up, Taylor RX and RxPonder for patients with hormone receptor positive, HER2 negative breast cancer, which are approximately 70% of the breast cancers that we see today. So with data from these 2 randomized clinical trials, we learned that most women, which is about 70 to 80% of these women who have early stage hormone positive, HER2 negative breast cancers, do not need chemotherapy. These women have excellent prognosis with anti-estrogen therapy alone, with no benefit from losing hair, developing myelosuppression, horrendous side effects from chemotherapy. The next step we learned is that we could find targets in the cancer, and we can add targeted treatment, biologic treatment, to the backbone of chemotherapy. So the discovery of the HER2 receptors on 1 in 4 breast cancers, and then the discovery of monoclonal antibodies that tackle the HER2 receptor is what led to the addition of targeted HER2 blocking therapy to chemotherapy. And this back in 2002 led to the discovery that adding HER2 blocking agents decrease the risk of cancer coming back by about 50% and improve the overall survival and cure rate of patients by about 30%. So these are drugs like trastuzumab, pertuzumab, neratinib that all tackle HER2. And then most recently, the biggest discovery in multiple cancer treatments with start of melanoma and lung cancers, we learned immunotherapy is another tool that we could use to tackle breast cancer. Immunotherapy is the concept of allowing the patient's own immune system to see the cancer and attack the cancer. One mechanism of resistance or survival of cancer cells is that cancer cells put blindfolds on the immune system. So even though the immune system is there and sees the cancer cell, it cannot act against it because it's blocked. So drugs like pembrolizumab take the brake off the immune system so the immune system can go and attack cancer cells. So pembrolizumab is a new drug that we add to chemotherapy in patients with triple negative breast cancers, which are the estrogen, progesterone, and HER2 negative breast cancer, about a quarter of the breast cancer that we see today. And then the other discovery was that we can adjust and we can tailor the intensity of treatment of the whole body, the systemic treatment, after surgery based on how the tumor has responded to treatment before the surgery. So TDM1, which is a drug antibody conjugate, is actually Herceptin that's loaded with a small chemotherapy molecule. I call it a loaded gun. The Herceptin attaches to the HER2 positive breast cancer cell and then pushes this chemotherapy inside the HER2 positive breast cancer cell to destroy the DNA of the cancer cell. So it's a targeted antibody that used after surgery in patients who did not clear their cancer with our initial treatment led to improvement in overall survival than our older conventional ways of treating patients after surgery. And then as of 2 months ago, a new clinical trial, Olympia trial, showed that another targeted drug called olaparib or Lynparza, a PARP inhibitor, could cure more patients with breast cancer related to BRCA mutation. 1 year of treatment after surgery improves outcomes compared to no PARP inhibitor. So another great discovery. So moving forward with a case presentation, and I'm sorry this is taken over by breast cancer, but this is my specialty. So we're going to look at a young woman, a 32-year-old female, who presented to us for a second opinion after being seen in her community with a new diagnosis with breast cancer. Most of the times at this age, it's a lump that's being felt in the breast. So she felt this lump in her breast. She presented to her primary care physician. Risk factors for breast cancer in her case was a strong family history with 3 close family members with breast cancer. She had used oral contraceptives and other hormonal methods to prevent pregnancy. She had no obesity, diabetes. She did not drink regularly. She was relatively healthy, had a bit of hypertension, some anxiety disorder. Her living situation was fairly stable. She had a boyfriend and his children. She worked in case manager. She did not smoke, did not use regular alcohol. She loved to do outdoor activities and sports. So her primary care physician appropriately ordered a bilateral diagnostic mammogram, which most of the times in women of this age is negative. She subsequently had an ultrasound of the left breast that confirmed that there was some irregularity in the breast tissue where she could feel that mass. The outside facility did not automatically look at the underarm area. It's not a protocol that's done everywhere. We here at the Breast Diagnostic Center in Fort Collins, we automatically, when we have a suspicion of cancer, we look at the underarm area on that same side to make sure there's no large lymph nodes. So she appropriately had a biopsy of this mass in the left breast, and the pathologist said, yes, this is breast cancer. It's a common form of breast cancer, the invasive ductal carcinoma. Grade 3 means rapidly proliferating tumor, goes along with a high Ki-67. It was a triple negative breast cancer, which, as I said, is one of the most aggressive forms of breast cancer. So she was referred to the surgeon, which is kind of the first step that the primary care physician has in mind. You have breast cancer, you need to have it removed, you have to take it out. So the instinct of patients is, okay, I have breast cancer, I want both my breasts off tomorrow. So she's referred to the surgeon. He recommends a double mastectomy. The patient says, I want reconstruction, so she's referred to the plastic surgeon. She sees the plastic surgeon, and immediately, within 7 days, very promptly, her surgery is scheduled. And the surgeon has a sentinel node biopsy in mind, recommended for patients who have tumors less than 5 centimeters in size and no swollen, palpable, feelable lymph nodes on physical exam. So they automatically say, yes, you're going to have a double mastectomy, remove the most superficial lymph nodes in the underarm area, and we'll start with reconstruction with placement of an expander and so on. So she says, you know, I think this sounds great. I want to go to Fort Collins because I hear great things about UCHealth, so I want a second opinion. So we presented fragmented care before when the patient sees the surgeon and the surgeon refers the patient to the plastic surgeon and the medical oncologist. Here, let's see what happens here. So here we have patient navigators extraordinaire who, once they see the case in the referral queue, they will automatically grab all the information about that case when it comes to imaging, pathology, notes from the surgeon, notes from the plastic surgeon, and everything is gathered and the case is put for presentation at Breast Tumor Board. Breast Tumor Board is a group of passionate people, as passionate that even if it's a snowstorm, we are there at 7 a.m. on Wednesday mornings to look at all new cases of breast cancer. So the case is submitted to the Breast Tumor Board, 7 a.m. on Wednesday. The case is reviewed by the tumor board team, and the patient is set an appointment with medical oncology, surgeon, patient navigator the day of the presentation. So the patient is seen by medical oncology, surgery, and navigation. On exam, she has a large tumor in the breast, about 7 centimeters, and she has palpable lymph nodes in the underarm area on that left side. The rest of the exam is fine. The patient is highly anxious. She knows she has a triple negative, large tumor in her breast with spread to the lymph nodes in the axilla. The patient counselor is involved the same day. And I have to tell you, that is a huge relief for patients, huge relief for the Medicare team, because we don't have the right words. We are thinking medical, whereas this patient needs emotional support. So big help. So what we do is, okay, you're not a candidate for a sentinel node biopsy. If you have surgery up front, as suggested, you need an axillary node dissection, which could lead to arm lymphedema. The patient needs radiation. So between surgery and radiation, more scarring, more risk, poor reconstruction ability, and high risk of long-term arm swelling. So we said, okay, let's double check these lymph nodes. We biopsy them. We put a radioactive clip in the nodes, so of course, with the guidance of the surgeon. And we say, we need a bilateral breast MRI. We want to assess the extent of the cancer. We want to make sure that we understand how many levels of lymph nodes are involved. And we want to make sure that the opposite breast looks fine. And we say, well, you're too young to have breast cancer. We know your mom's genetic testing was negative, but maybe that was done years before. And the genetic testing has changed significantly over the years. Now we test for 80 genes, where in the past we tested 2 or 3 genes. So we refer her to genetic counseling. And then she's a 32-year-old woman who's going to need chemotherapy for triple-negative breast cancer. Does she want to have children in the future? So another aspect of care that sometimes can be overlooked by a surgical team or even a medical oncologist if they don't have the team around them to remind them and pull their sleeve, hey, fertility preservation. So we refer her to the reproductive team. And then we get the baseline blood test and echocardiogram, make sure her heart is healthy and could tolerate chemotherapy. So the plan of care is established by a team of people. It's not the surgeon saying this is what we do. It's not the medical oncologist saying this is what we do. It's a team of people saying how can we move forward the best? So we said, okay, we could start with surgery up front, but if we do the surgery up front, she's going to have a double mastectomy. She has going to have a node dissection on the left side because she has cancer in the lymph nodes. The potential complications are, okay, you need to recover approximately 4 weeks from this complicated surgery. And if there are complications, infection, failure of expander, that delays the treatment of the whole body. And we know patients with breast cancer have disease in other parts of the body. And that's what we need to tackle most importantly than the local therapy. So we delay the systemic treatment. We could potentially compromise her outcome, her chance of being cured. And on top of that, by removing all the lymph nodes in the underarm area, we give her about a 25% chance of developing long-term arm swelling. That could be a long-term, lifetime complication, which is serious for somebody who's 32. After surgery, we start chemotherapy, and this is a 20-week treatment of drugs that could be toxic. Then she needs radiation therapy because she has large tumor with positive nodes. And then we're going to hope that the treatment worked, and we're going to keep a close eye on her. And time alone is going to tell us, did she get cured or not? The second option is keeping in mind that her cancer, even though visibly in the breast and the underarm area, is 70% of the time spread in other parts of the body as microscopic seeds that we will not be able to see with PET scans or CAT scans. So neoadjuvant chemotherapy means let's start treating with chemotherapy before we remove the tumor, before we sample the lymph nodes, because that would give us an immediate ability to kill cancer in multiple sites. So we will start treatment right away. We usually can get treatment started within 2 weeks. We could add other drugs to the backbone of the standard drugs because we have data that, for example, carboplatin, which is highly effective in triple-negative breast cancers, can enhance the chance to clear the cancer in the breast, clear the cancer in the lymph nodes, and give us what's called a pathologic complete response. That can teach us, based on how the tumor in the breast and the lymph nodes respond to treatment, it would give us a hint on how microscopic disease in other parts of the body would do, right? Because the response in the breast predicts response in the rest of the body. Then, if we can shrink this tumor, we could limit the amount of lymph nodes that we take in the underarm area. That could help us avoid a node dissection if the most superficial sentinel lymph node is negative, and that's a 50% chance with the current treatment. We can minimize the risk of lymphedema, and then we can decide based on how much response, how much tumor is left in the breast and lymph nodes, what do we do next in case there's cancer left in other parts of the body. So multiple benefits from that. So as we're talking about these plans, we say, okay, you need help. You need physical therapy, because if you do end up having a node dissection, we can prevent arm lymphedema if we proactively look at that. So our physical therapy program has a pilot program of arm lymphedema prevention. We can refer you to integrative medicine because you as a patient want to be an active player in the treatment. You want to live healthy. You want to help yourself mitigate the side effects of treatment. We can enroll you in the cancer rehab program to keep you strong. We can work with a counseling team because you need emotional help. You need financial help. Your family needs to be part of the team and they need help. And then we want to educate you about how to take care of yourself, how to be a cancer survivor, how to stay active, how to eat right, how to support you emotionally with support groups. So as we talked about these things, the patient decided, okay, she looked at the pros and cons of everything, and she decided to go with option B, which would be, let's try to treat everything at the same time, keep the tumor in the breast and nodes as tellers of how we're going to tailor the treatment of this cancer. And she understood that if we did the systemic treatment first, she had a 70% chance of having shrinkage in the tumor of the breast and the lymph nodes. She had the understanding that she might be able to avoid an axillary node dissection. She knew that we have pathologists who can be in the operating room to tell the surgeon that if the sentinel node is positive, the next step is to do a node dissection. And she knew we had a very good research team with research programs that could help us avoid radiation therapy if the whole tumor was cleared both in the breast and the lymph nodes. That's an NSABP B51 clinical trial, which is a national trial that we have open here in Northern Colorado, looking at patients who have a complete resolution of the cancer after the chemotherapy. Half of them have radiation and half of them do not, with the question on, can we omit radiation in these patients? And then she also knew that we have another clinical trial that was looking at immunotherapy versus observation being the standard of care in some of the patients. Immunotherapy, if she still had cancer left in the breast or in the lymph node after the frontline chemotherapy. So she knew her options. If you could help me advance the slide. Oh, there we go. So again, emphasizing what I talked to you about, tailoring the treatment after the surgery based on how much response in the breast we had. And we had, if she had a complete response in the breast and in the lymph nodes, we knew there would be no further benefit from more chemotherapy, and her prognosis was excellent. We knew that she might be eligible to omit the radiation therapy if she enrolled in the NSABP B51 trial. On the other hand, if things didn't play out the way we all hoped for, and she needed, if she had residual disease in the cancer or the lymph nodes, she would have needed additional chemotherapy, or she could have enrolled in the immunotherapy clinical trial. So as I'm concluding my presentation, I know it sounds very complicated, and it is in our minds too, and it is overwhelming for our patients, as it is overwhelming for anyone who's not familiar with the cancer field. And this is where I leave the room and Jamie, the patient navigator, stays in the room to talk further with the patient and clarify. She will tell you exactly what she does. So I'm gonna bring Jamie to the podium and let her explain the next step in care. Thank you for your attention.
Okay. Thank you everyone for coming today. My name is Jamie Callahan and I'm one of the nurse navigators that works here at the Cancer Center with Dr. Medgyesy. And I really want to thank Dr. Medgyesy for her great presentation, because that really is a good picture of all the information that we really give to our patients on a daily basis. And so I just want you guys to take a minute and think about, you know, if this patient in this scenario, what if it was you or your friend or your daughter or your mother? And I know this isn't fair because I didn't tell you there would be a quiz, but you know, what if we'd had this conversation and then Dr. Medgyesy left, and how many of you would know exactly the plan and what needs to be done? I'm guessing it's not a lot. And I like that because that means that I have a job. So it's really my job here to help make sure that patients are understanding everything, they're getting all the information that they need, and that these appointments that we're setting up, because this is a very busy time for patients, the time from diagnosis to treatment start, there's a lot of different appointments and a lot of different moving pieces. And people without the medical background really just do not have that knowledge to know what should happen next and in this order to really make things as efficient as possible. So that's where I come in my team. So I wanted to talk with you a little bit about navigation within UCHealth, because it's a really fantastic service. I think I may be biased. But today within UCHealth, we actually have 9 nurse navigators. So I am one of them. I am the team lead. We have 7 navigators here at the Harmony campus, and here at the Harmony campus, we are all site specific because this is a larger campus. We have a lot more providers and a lot more patients that come through the doors of this campus, as well as the radiation facilities that are on site here. So every new patient to the cancer center, whether it's medical oncology, which is really the whole body treatment side, or radiation, the navigator team is notified of everybody. We have 2 general navigators, one in our Loveland office and one in our Greeley office. They actually, I think, have a little bit of a harder job because at least here in Harmony, we're able to be site specific. So for example, I work mainly with patients who have breast cancer. And so I'm really able to understand the disease at a level that allows me to help answer questions and allows me to help anticipate issues, where our generalist navigators have to understand every single disease. And that's where we've actually been able to get a lot of support from the foundation. We've been able to access foundation funds to help provide nurses with education. So whether that's new nurses to our team who really need to learn about their disease site, or our generalist navigators who say, you know, I just cannot be an expert in all of these, but here is a scenario that's new, that's coming up more, that I need more information about. On the navigator team, we are all registered nurses, and 8 of our 9 navigators are actually OCN certified, which is an oncology certified nurse. So we are experts in our fields, and we do have a few nurses that are breast care certified, especially for those that work with the breast team. We are considered a community benefit, and what that means is that somebody could call in and say, you know, my daughter is in treatment in California and I want to know what she's going through, but I don't want to ask her because she has already been asked by 10 or 11 other people and I don't want her to have to repeat it. I get those calls actually quite a lot. And so I can talk to people about, here are different things that I would be thinking about if this person was sitting right in front of me. Sometimes it's just answering questions about the expected side effects, how this person may be best supported based on what they're going through. But I think it's important to know that people do not have to be patients of UC Health in order to talk to a navigator. And so we do get calls. We'll also get calls about, you know, I found a breast mass and I don't know what to do. I don't have any doctors to see, but I'm calling the cancer center, and those usually get routed through to me. And so I'm able to tap into my resources to help get this patient's care moved forward, and help navigate them through the healthcare system. So my job is a lot of things in kind of a short period of time. But this time frame that I'm going through right now, this diagnosis to the start of treatment, that's really where the navigators are the most active. We do follow patients all the way through treatment, and we are the ones to trigger the survivorship care plan at the end of treatment. That is the document that patients get at the end of their curative intent treatment that basically summarizes, here's everything you've been through, here's long-term side effects that are possible, different things to watch for, general health recommendations. That way, if someone ever moves out of state, they have their cancer record on this 5 to 10 page document, and it's all pretty succinct. But we are most active in the time from diagnosis to the start of treatment. And that's really because that's when the most moving parts are there. So like Dr. Medgyesy reviewed, for our patient here, we're talking about fertility preservation options. We're talking about a breast MRI. We're talking about additional biopsies. And from my standpoint as an expert on the health system, I'm really knowing we really need to set up that breast MRI before we set up the biopsy, because if I have someone who has a biopsy, then has a breast MRI, there's a chance based on the breast MRI she could need another biopsy, and then we have to send her back again. And so it would be much better if we say, let's do the MRI first. That way, if we identify an additional area to biopsy, she's already scheduled for a biopsy, we can just add it on. And these are the things that, you know, that is within my mind, and that's what I'm thinking about, just to really make sure that everybody's time is utilized and respected. And so that's really where my focus is. In addition to providing education, we always talk about referrals to our support services and help really guide our patients into treatment. And so really, I like to get to know my patients. We try to screen for any barriers or issues, both that the patients identify. So if patients come in and they say, you know, I'm really struggling with this. My parents both died of cancer. I'm really terrified that that's where I'm going and I can't even consider anything else. That's when we go back and say, okay, let's talk about a counselor. And some people come in saying, I know I need to see a counselor. Other times there are things that people haven't even thought of, but because of my expertise and my training, I'm already thinking about things like this for them. So for example, if somebody comes in November and we know that we're looking at chemotherapy and radiation, and it's November, so they're going to hit their high deductible right now. And then in January, their insurance will reset and they're going to have to hit their deductible again. That can be very financially toxic for people. And sometimes people aren't even thinking about that yet. But in the back of my mind, because of my training and because of my expertise, I'm already bringing that up to say, listen, I'm concerned about this for you. Can we please connect you to the social work team to get screened for financial grants? Because as you have to meet this deductible twice now, this is going to be something that's really difficult. So really just trying to anticipate needs and help eliminate delays in the start of treatment. So if I know that there's a certain test that takes a while to get authorized through insurance or takes a while to get scheduled, that's really going to be top on my radar to make sure that we get on the books. That way, as the patient, they don't need to worry about getting all those things scheduled and making sure they're in the right order. They just really need to focus on, let's absorb all of this information, which we know you don't. So that's why I get calls a lot from patients saying, I don't understand why we're doing this. Something's not feeling right. This sounded really important in the visit and I cannot remember why. Those are all questions that I get all day, every day. And that's really where I want my patients to be able to focus, is understanding their diagnosis and their treatment plan and making sure that they're 100% on board with that and not worried about, well, I have to get authorization for this scan or I have to make sure all these tests are set up in the right order. And I'm also looking at different things, like if my patient says, well, my family has one car and that's working for us right now, that's great. But I also know if we're talking about daily radiation, which is Monday through Friday, if that one car is with someone at work, we're either looking at this person isn't able to work, or my patient's taking a taxi to treatment. And so those would be situations where I'd say, listen, we have a lot of resources available to help so that you're not taking all this on. Let's help you. And so from that standpoint, I'd really like to thank everybody that's on and everybody in the community, because we really do have, I think, one of the most supportive cancer programs that I have ever seen in my whole career, to really wrap around these patients who are already dealing with cancer in general, and that's enough. They don't need more. So the fact that we can bring in our social work team and our counselors and our dietitians, and our patients aren't having to go and ask Dr. Google all these questions and maybe get inaccurate information, it's really, really fabulous. So thank you for that. And I will actually pass it off to Jonathan Salazar now to talk more about these support services that make my life much easier. Thank you.
Hello, everyone, and thank you for being on today. And it's really tough to follow these amazing presentations, but really it is about coming together as a whole team and supporting our patients. So as Jamie was speaking about connecting our patients to all of the services we have, we're really concerned about not just treating the cancer, not just moving into supporting patients with chemotherapy and radiation as conventional treatments, but we're really looking at the whole person and the approach to care that we know is needed in order to have a successful outcome. Because as Jamie was alluding, all of these potential barriers to care are going to completely come into play and potentially negatively impact an outcome if we're not able to address them quickly. And so in this visual, you can see all of the supportive services that come into play aside from just radiation and chemotherapy treatments for patients, because all of these services can come in at any stage of treatment, whether it's early on, as Jamie and her team are referring to all of the services on my teams, because she and her team are identifying barriers in transportation, financials, any psychological issues, or really any of those at the beginning, and then also support any of these during treatment. As we know, during their cancer journey, many other things can come up. If they are struggling to begin with, there could be an exacerbation of those in the middle of treatment. And then we also know that once you go through the cancer journey, things don't exactly feel the same after patients are complete. And so we also want to wrap around the patient and support them with all of these services for their survivorship. And this isn't just, I think it's important to know that it's not just for the patient, this is also for the family, because unfortunately and fortunately, cancer care is not a solo journey. It is truly situation in which the whole family and the patient really needs the rallying support of their social system and their social support, family, caregivers, friends, and employer really as well. I would like to touch on the fact that a lot of these services that you see on the screen have been supported by a lot of our foundation support, a lot of donors in our community, and then philanthropic support to ensure that we're always at top of the most recent and up-to-date findings, and that everything that we're doing is at the top of our evidence-based practice. So thank you for that. I want to talk a little bit more about the supportive oncology services that we have here at Northern Colorado Cancer Services. So we have licensed clinical social workers, and these professionals are here to support resources, transportation, respite care. We know that there's a lot that's taxing on patients and families, and then also the psychosocial or the psychological interventions. So whether that's counseling for coping, distress, anxiety, really assisting the whole family unit, particularly when we have young moms with young children. We're helping to connect the dots with school guidance counselors. We're helping to connect the dots with any other community resources around that, and really doing some legacy training and legacy support for patients. We have registered dietitians, and these patients can access, and our providers and our navigators can refer to support patients during their treatment for their intervention. If they have taste changes, if they're having struggles with knowing exactly what they should be eating during treatment, it's certainly supporting and keeping them out of the emergency room because they can't drink enough water or have the right nutrition. And then with survivorship, coming in and saying, okay, what can I do? What do I have then the empowerment to do to avoid this in the future or avoid this for other family members? We also have our genetic counselors, and these professionals are extremely important also to the cancer treatment because they can help identify if the reason for this patient's cancer has a genetic component. And not only is that helpful for the patient themselves to know there's a potential for a very directed treatment option, but also then look at the family and help in the prevention aspect. Because there could be a mutation, then there could be supports for the family to really look at and say, I can really start surveillance earlier. I can go get checked up for whatever the mutation in a potential gene could be and avoid a future cancer. We have massage therapists. We know that this is an anxiety producing process, and we know that relaxation, and we know that good mindfulness can be really helpful to a patient as well. We know that there can be an increase in inflammatory response when patients are always under pressure of anxiety. We have licensed acupuncturists. These professionals help with a variety of symptom management. Peripheral neuropathy, which is that numbness and tingling that patients will often get from treatment in their fingers and their feet. A lot of pain management. Great services for patients. Again, mindfulness-based stress reduction is an opportunity for patients to meet with an MBSR teacher that can really help them with some mindfulness techniques, help them not anticipate and go down, dark roads where they're increasing anxiety versus not. We have yoga, and everybody loves yoga. It's a great opportunity for patients and also their caregivers to come in and have an opportunity of restorative yoga to help them. Palliative care, and I think I want to call this out just a little bit more. I think there's a synonymous, sometimes that's erroneous in terms of equating palliative care with hospice, and I want to think if you could all think of palliative care as a broader circle and hospice being a smaller chunk of that in the center. Palliative care is really another support, clinical support team that can help with symptom management, and that looks it's a very multidisciplinary approach, and it looks like a physician, a social worker, and a nurse navigator as well, supporting the patient with additional therapies, medical treatments that can help them during their care, and patients can come into palliative care and move out of palliative care once they're done, or they can help them transition into a hospice setting if that is what is needed. So there's both options there. I want to call out how amazing it is for my team, particularly the oncology social work team, to get the support of our foundation and our amazing donors that really help patients with financial toxicity. Financial toxicity is really another word for financial distress, financial burden. This can happen to a variety of our patients, and it's not just those patients that are uninsured. It is patients who might have insurance, but like many of us, could be the primary sources of income for their family, and now they're affected by cancer. They carried debt to begin with, and now they're coming in and it's exacerbated by their cancer. And then all of a sudden, all of their treatments, although the long-term goal is worth it, the immediate effects do have an impact on their ability to continue working. So when that happens, then patients, of course, encounter the higher debt. They have trouble paying for their household expenses. These are things like their rent, their mortgage, their heat bill, their light bill, and transportation needs. And sometimes these patients have to file for bankruptcy. The ability that the foundation support provides us is to be able to go to a patient and tell them, you know, you qualify for assistance so that you can worry about getting to your appointments, you can worry about meeting with your providers and your treatment, and we can help you keep the lights on. We can help you ensure that we can get that mortgage paid for this month through the resources that are offered because of our philanthropic support in our great community. So these are great supports for our patients. We have wonderful opportunities then to connect patients, because we know that when there are patients who encounter financial toxicity, it leads patients to then potentially avoid a certain care, a treatment. And if that happens, they're in a non-compliant situation, we know that'll lead to poor outcomes. Patients often then have poor physical health, and they can have a decreased social support system. It increases their worry, and then it leads to potentially depression and other mental health concerns. There was a recent study that was published that talks about not only the impacts, the negative impacts of financial toxicity on a patient, but that it really does have a correlation with mortality, because there's a constant worry, there's a constant concern. And so when our nurse navigators connect social work and our financial case coordinators into the care of patients, it really helps us directly connect with them, and through the foundation who administers our funds from our community, really help support all of these patients' daily living expenses, and that is a huge burden lifted from them. So I'd like to go ahead and invite Erica Seamers back on, and thank you so much.
Jonathan, Jamie, Dr. Medgyesy, thank you so very much. We do have one question that came in through our audience that I'd like to pose to Dr. Medgyesy at this point, and I will be reading it from my phone because that's where I have it here visible. Dr. Medgyesy, my 77-year-old mother was recently diagnosed with stage 1A breast cancer, ER/PR positive, HER2 negative, clinically node negative. She had a successful lumpectomy and will be taking an estrogen-blocked drug for 5 years, no radiation or chemo. Her oncologist said there is a 10% chance of the cancer recurring. My mother will have follow-up visits every 4 months with her oncologist at the Harmony Cancer Center. What we have not thought to ask yet is, how will she be monitored and tested to watch for a recurrence? What could a recurrence look like? A new lump in her breast, cancer elsewhere in the body, and/or something else?
Thank you so much. It's a very good question. It's a convoluted question. So fortunately, this is a very favorable breast cancer with excellent prognosis. I can tell you that back in the 90s, we took patients who had early stage 1 breast cancer, and every 4 months when they came for their follow-up, we would do blood tests and we would do CAT scans and bone scans to look for cancer recurrence or cancer coming back. Of course, they had their physical exams and their mammograms routinely. And we put patients through a lot of tests to find cancer earlier than the cancer would have caused symptoms. And we learned that with randomized clinical trials, we learned that whether we did these tests or we didn't, the outcome was the same. And that's not to put a negative connotation or a hopeless statement to a stage 1 cancer. This is just to show that whether you catch cancer when it gives symptoms or you catch it incidentally because you did a CAT scan in the absence of symptoms, is the biology of the cancer that determines outcome rather than how quickly you find it. So there's 2 types of recurrences that we look for. One is a recurrence in the breast and the lymph nodes, which is detected with physical exam. So that's where the value of seeing the provider every 4 months for 2 years, every 6 months between year 2 and 5 and yearly thereafter comes in place. So that is detected with physical exams and then once a year mammograms. And then the risk of cancer coming back to other parts of the body, which is caught based on how the patient feels and how their lymph node exam checks out, how the lungs sound, how the abdomen feels, but most importantly, how the patient feels. And we always tell patients and we reassure them that as long as they feel good, as long as their physical exam is normal, they're cancer proven unless otherwise. So we say well, they're cancer free until proven otherwise. So we do not do sophisticated CAT scans or PET scans or blood tests like cancer markers to look for cancer in these patients with excellent prognosis. So mom's follow-up is breast exams, lymph node exams, general exams, and once a year mammogram. And time alone is going to tell us if this cancer is gone or not. If she's cancer free at 5 years, we hope she's cured. Some cases, like this case in particular, I think after 5 years, the prognosis is excellent, and we usually release patients to their primary care providers at that time. For higher risk patients, we sometimes elect to keep watching them up to 10 years. I hope this is answering your question.
Very good. Thank you so much.
Thank you.
We are so grateful for your expertise and for the expertise of your team to be able to answer the incessant questions that do come along with the cancer diagnosis and care and concern for our health. So we can't thank you enough. Again, thank you all so very much for joining us today. Thanks to our audience. You've been a great participation. We're glad that you tuned in to learn more about cancer care in our community. Our foundation's purpose is to empower community members to live healthy, generous, and meaningful lives, and we are so grateful for all of your support for the foundation's efforts in our community. To follow up on some of Jonathan's and Jamie's comments about the importance of community support to help our cancer patients in need, our family, friends, and neighbors, if you're so motivated to contribute to our cancer patient assistance funds to help some of our local community members navigate their cancer journey more easily, you're welcome to visit our website at UCHealth NoCo Foundation .org/donate. Also know that, as you're probably aware, the month of October is focused on cancer awareness, and the foundation is grateful for the support of many generous businesses who host community events and raise funds to support cancer patients. You'll see listed on the slide here some of these upcoming events, many of which have been annual events in support of cancer patients in our community. So I hope you'll check out some of these great opportunities to provide support. Again, thank you so very much for joining us today. We wish you a great afternoon and a season of good health. Thank you.